Okay, I think we're going to start. Thank you everyone for joining us today on our billing and coding series. Today we are privileged to have Kimberly Simmons discuss inpatient billing for us. So I'm going to let you take it away.
Thank you. I'm Kimberly Simmons, and I'm one of the compliance managers for the Department of Medicine. I actually cover palliative care, general internal medicine, endocrinology, rheumatology, geriatrics, and the hospitalist. And today I'm going to go over inpatient coding and billing. Here's just some important dates to keep in mind on some of the sessions that, in case you don't already have the dates that we already have pre-approved. The next session is going to be April the 8th, which is going to be on time-based coding. May the 13th will be on procedure coding, and last but not least, June the 10th we will cover diagnosis, coding, and billing. So some important information and disclosures is you can sign up through MyQuest, or you can view our sessions live or via WebEx. All of our presenters have no disclosures. You can obtain CEU or CME credit for attending these sessions. If you are an APRN, you will receive your certificate via MyQuest, but for any for any physicians or APs, our CME office will email you your certificate. So for inpatient, can everyone please make sure that they mute their phones? Thank you. Okay, so some of our objectives for today is inpatient coding, and I'm going to describe the difference between an initial hospital care, subsequent hospital care, discharge management, and consults as defined by CPT. We're going to go over some examples of documentation to identify the history, the exam, and the medical decision making. And then we're going to come up with the correct level of service for the initial care, for some subsequent care visits, discharge management, all based on the documentation that we're going to review. Some of you may hear inpatient initials referred to as HMPs, or sometimes they call them admission codes. For subsequent care, you may hear those called referred to as daily progress notes or follow-up visits. Now, what we are not going to cover today are specific levels of services other than inpatient, emergency department codes, observation codes, preventative services, CPT codes that fall outside of the E&M category, any kind of EPIC issues, APP guidelines, specialty-specific documentation, and workflows. So I'm going to just do a little high-level overview of some of the last sessions in case some of you did not get to attend or listen to those. E&M, which is evaluation and management, is composed of 3 key components, which is your history, your exam, and your medical decision making. Please keep in mind that your medical necessity must always be an overarching factor in all services that you bill.
Please just try to mute your computer so that we don't get that background noise.
Okay, the inpatient codes. Let's talk about first, what does inpatient mean? Inpatient status is assigned for patients whose condition requires admission to a hospital. Sorry, I think I skipped a slide there. Sorry about that. So back to what inpatient means. Inpatient status is assigned for patients whose condition requires admission to a hospital. Inpatient care refers to medical treatment that is provided in a hospital or other facility and requires at least 1 overnight stay. For the purposes of healthcare coverage, insurance plans require you to be formally admitted to a hospital for a service to be considered inpatient. The inpatient E&M categories is the initial hospital care, subsequent care. We're going to go over some consultations and hospital discharge management. As you can see here, in initial hospital care, you still need 3 of the 3 key components as well as consultations. But notice that with your subsequent care, or what I said was sometimes referred to as progress notes or daily follow-up notes, you only need 2 out of the 3 key components. In hospital discharge management, later on, I'll go into more detail about that. This is the audit tool that you may recall from some of the last sessions. This is the E&M audit tool, and just so that we can just do a quick recap of it, we have our history section, which has your HPI elements. You will see your review of systems, and then your past family and social history. We have our exam section. And then last, we have our medical decision making, which is made up of 3 sections, which is your diagnosis and management options, your data, and then your table of risk. For your medical decision making, keep in mind that 2 out of the 3 areas are going to determine your level of medical decision making. So for initial inpatient E&M codes, the codes are 99221 through 99223. Let's talk about the minimum documentation requirements that each of these codes call for. So for a 99221, you must have a detailed history, a detailed exam, straightforward or low complexity medical decision making. For a 99222, you need a comprehensive history, a comprehensive exam, and moderate complexity medical decision-making. You'll notice that with the 99223, the highest level of care, it's the same. You still need a comprehensive history and a comprehensive exam, just like you do with the 99222. The only difference is that you need high complexity medical decision-making with the 3. And again, remember, this is initial inpatient, so you have to meet 3 of the 3 key components. So for subsequent care inpatient, notice that you only need 2 of the 3 key components. These codes are 99231 through 99233. For a 99231, you would need a problem-focused history, a problem-focused exam, straightforward or low medical decision-making. For a 99232, you need an expanded problem-focused history, expanded problem-focused exam, moderate complexity. For 99233, detailed history, detailed exam, and you need high complexity medical decision-making. Again, keep in mind that it's only 2 of the 3 when it's sub-care. So let's talk about consultations. The definition of a consultation is you still need, first of all, let me just stress that you still need to meet your key components in order to build the level of service, still build your level of service. But let's focus on what you need first. You need 3 R's before you can even move on to determine your level of service. Those 3 R's are a request, you need to be render an opinion, and you need to be given a reply back. Once you have those 3, then we can move on to determine which level of service it will be. Now, I will say that with inpatient, it's not as difficult as it is with outpatient, because with the inpatient, we're sharing the same medical, and we're sharing the same chart. So usually you have that request on that chart. You are rendering your opinion right then, and then your reply back is already right there in that inpatient chart. So the consultation, what the definition actually is of a consultation, like I said, is that this type of E&M service is provided at the request of another physician or an appropriate source to either recommend care for a specific condition or problem, or to determine whether to accept responsibility for ongoing management of the patient's entire care, or for the care of a specific condition or problem. You will see that it's pretty much the same as an inpatient. Initial inpatient, you still have to meet those 3 R's again. I mean, the 3 key elements, excuse me. So inpatient consultation codes, 99251 through 99255. You need a problem-focused history for the lowest level, the 99251. You need a problem-focused exam. You need straightforward medical decision-making. For 99252, you need an expanded problem-focused history, expanded problem-focused exam, straightforward medical decision-making. For 99253, a detailed history, detailed exam, low complexity. For 99254, a comprehensive history, comprehensive exam, moderate complexity medical decision-making. And for a 5, a comprehensive history, comprehensive exam, and then again, high complexity. It's kind of like the inpatient one that I showed you. The only difference between the 99254 and the 55 is that the medical decision-making is of moderate for the 4, and you need high for the 5. Now, for hospital discharge services. These codes for hospital discharge, day management codes, these codes are to be used to report the total duration of time spent by a billing clinician for the final hospital discharge of a patient. The code includes the final examination of the patient, discussion of the hospital stay, even if the time by the clinician is not on that date is not continuous. Instructions for continuing care to all relevant caregivers, any kind of preparation of discharge records, prescriptions, any type of referrals, going over medications with the patient, all of that is included in your hospital discharge services. There are 2 codes for hospital discharge management, and they are time-based. There's a 99238 and a 99239. So if you spend less than 30 minutes discharging the patient, you would bill the 99238. If you spend greater than 30 minutes discharging the patient, you would bill a 99239. So now let's get into some examples. Here we have history and physical. We have a chief complaint of abdominal pain. We have, basically we're looking for, if you recall, we're looking for those 4 elements of HPI. So we have, let y'all read through this for a second. But basically, as you can see, we have that the patient is experiencing abdominal pain. That could be location. It's radiating. That could be quality. Could also use quality as describes as feeling as if he was run over by a truck. We have timing, relatively abrupt. We have signs and symptoms because it's accompanied by fever, nausea, and diarrhea. So right there, we have 4 elements of HPI. To continue, we have a past medical history. They've also included a surgical history. We have a family history, and we have a social history. They've reviewed medications. We have our review of systems. Let's count to make sure that we have at least 10 review of systems. We have constitutional, eyes, ENT, respiratory, cardiovascular, GI, GU, skin, heme lymph, musculoskeletal, neurological, psych, endocrine, and allergies. So we have at least 10 review of systems. So we're good to go there. For our physical exam, we want to make sure that we have an 8th organ system exam. So let's make sure, let's go over and count those. We have our general appearance, that's constitutional. So we have 1. We have our eyes, which is 2. We have ENT, which is 3. We have cardiovascular, 4. Respiratory, 5. We have the GI, which is 6. Musculoskeletal, 7. Skin or integumentary, 8. We have neuro and we have psych. So we have more than enough to qualify for our 8 organ system exam. They reviewed labs. And for our assessment and plan, we have an acute post-ERCP, pancreatitis. We have AFib. We have hypertension. We have obstructive sleep apnea. Patient is being admitted for IV fluids, symptom management. The providers made it very clear at the bottom that the patient will be admitted under inpatient status, expected to require 2 midnights in the hospital. So that should give us a clue right there that we're looking at an initial inpatient visit. Let's see what we're going to come up with. Had abdominal pain, if you remember. We talked about that location. We talked about timing. We went over quality. And then we went over signs and symptoms in our HPI. We also made sure that we had our review of systems. As you can see here, already checked with constitutional, the eyes, ENT, cardiovascular, and so on. So we at least had 10, and we had our past family and social history. So that gave us a comprehensive history. To move over to the exam section, in looking back, we counted all of the exam elements here, and we knew that we had 8 organ system exams. So we had the constitutional, the eyes, the ENT, respiratory, cardiovascular, GI, and so forth. We even had probably more than that, but we stopped at 8 because that's the highest. So we have a comprehensive exam. Now with the medical decision making, this patient was being admitted to the hospital. So it was their first visit. So it's a new problem with additional workup. If you remember, they were going to order labs. So we have a new problem in the diagnostic management section, We have the new problem, which gives us 4 points. In the data section, we have labs, which gives us 1 point. And then in the medical decision making, there's several ways that you could look at this. We had several problems. We had AFib, we had hypertension, we had obstructive sleep apnea. They were there for an acute post-ERCP. The patient was being managed, had prescription management. We had labs. So we could look at that this would fall into moderate, because we could say it was either too stable, they had at least 2 stable chronic illnesses. We could look at it as maybe them having an acute illness with systemic issues, and we were providing prescription drug management. So as long as we have at least something in that area, in the moderate medical decision-making, that's where we're going to fall. We did not read, or the provider did not document any kind of chronic severe exacerbation, any type of threat to life, abrupt change in altered mental status. So we didn't talk about DNR, any kind of type of poor prognosis. So we have moderate medical decision-making. So our history is comprehensive, our exam is comprehensive, and then we have moderate medical decision-making. So our code comes out to a 99222. Remember, the reason this comes out to a 99222 is we have to meet or exceed in all three of the three key components. So with that being said, we couldn't bill a 99223 because we have that moderate medical decision making. Sure.
This part here. Medical decision-making data, table of risk. I get how you got there based on the criteria, but then how do you decide?
Between.
I know from Gestalt it's moderate, but then you have this and this, and how do these three factors play into your decision?
Because only in your medical decision making, in that table, you need 2 out of the 3. Yes. So you can drop the lowest. Does that make sense, Paula? Excuse me, Megan, that makes it, okay. Now, we would have been able to bill high if we would, in the table of risk, if something would have been, if this problem would have been like I was saying, if there was some kind of documentation to the effect that this was a chronic severe exacerbation or threat to life or poor prognosis or DNR, altered mental status, we didn't have any of that. Everything pointed towards the moderate decision making. And that's why the medical necessity came out to be, the medical decision making came out to be a 99222.
You drop one of them, 2,
Mm-hmm.
and you come up with moderate, or for options of moderate. Why do you say moderate versus 4 high?
Because you need 2 out of the 3.
You have 2, right? You have the 4 and the moderate. Right, the balance.
Because you can you have 4 for the diagnosis management, and then you have the moderate. You have to have 2 out of the 3. So basically, if I don't have in the data, if I would have had 4, then I could have went with a 99223.
So between the diagnosis management options,
And
the complexity of data and the table of risk,
it's
you
together.
those 2 out of those 3 have to meet or exceed.
Right.
Gotcha. In order to go to
So,
that level.
right.
Got it, okay.
You see, so
That's where it's
that,
hard.
right.
Yeah. Okay.
Yeah. So, but if we would have had it in the data section, let's say that they would have did radiology, maybe they did a summary of old records. If our data would have been bumped up higher and it would have come up to say 4 points, then we would have met the 99223.
But the data would have to go up to 4 to really be
Correct.
considered.
Correct. Does that make sense?
I think what's confusing, like the 2 out of 3 is multiple times, so it's,
It-
yeah, I
it's-
took exam this, and then it's 2 out of 3 down there, and then it's 2 out of 3 up there.
Exactly.
That's kind of weird.
Exactly. It's inpatient is the hardest. It's harder, a little bit harder. So let's move on to this next note. We have a history of present illness. This patient is post-op day number 1, was found to be resting comfortably. She was ambulating, voiding, and tolerating PO diet without difficulty. We have her hospital course. We have our physical exam. So let's look at the physical exam and see how many elements we have there. On our physical exam, we have constitutional, we have ENT, which is 2, we have cardiovascular 3, respiratory 4, abdomen or GI 5, skin 6, neurological 7, psych 8. When I said abdominal, GI, the reason I was able to count that as an organ system is because it says soft, non-tender, positive bowel sounds. If it would have said something like abdominal, obese, then that would be considered a body area and not an organ system. So we were able to use that as GI. So we have an 8 organ system exam there. We have medications, we have labs. This patient is status post alcohol septal ablation, hyperlipidemia, and is going to continue on statin. Hypertension is controlled. Diabetes doesn't say that it's out of control, so we have to assume that it's controlled. We're going to continue to monitor this patient and plan for discharge in the morning if the patient remains stable. So let's put this note together. I want you to notice that I did not fill out the history section. The reason I didn't fill out the history section was because we didn't, if you notice, we did not have a social history, family history, all complete review of systems, 4 elements of HPI. So I didn't even fill out the history section. This is not abnormal. This is normal to have, it's not relevant to do. This is a sub-care initial patient visit, or should I say progress note, daily progress note, follow-up, however you want to, whatever name you're used to calling it. And remember, we talked about this at the beginning, you only need 2 out of the 3. So you're not going to find that each in the hospital stay that a provider is going to do a review of systems all over again, past family, social, medical history all over again. It's not relevant. So I just moved on to the exam section, and we counted those elements, and we had an 8 organ system exam. Remember that we had a couple problems we were talking about here. We had that hyperlipidemia, we had that hypertension, we had diabetes, we had that the patient is status post-alcohol septal ablation. So nothing states in this documentation that anything is unstable, high risk, out of control. So we have 4 problems here. So we have to assume that they're stable. So in the diagnosis management section, we have 4 stable problems. Remember that they were looking at labs. So in the data section, you have one for lab. And then there's several ways to look at this one as well. We have, they're continuing on statin. So we could look at this as prescription drug management, or we could say that they have 2 stable chronic illnesses. So this is fallen into the moderate decision making. So for our exam, you will see that we have it doesn't go up to comprehensive. So we had a really nice exam. So it's detailed exam, which is the highest you need to go. And we have moderate medical decision making. Remember, this is a sub-care note, so we only need 2 out of the 3. So this would be a 99232.
For subsequent care notes, don't need any actual HPI. You can just do like a 24-hour update. Don't need to include any medical, social, family history at all.
Right. Yeah, as you all go back to it, you usually will see something pretty simple like this that just goes over post-op day, 1, the patient's found resting and comfortably in the bed, she's ambulating. That's usually what we would see, because you don't, like I said, it's follow-up care. We're not expecting you to be taking a past family social review systems, all of that all over again. As you can see, we have those labs. Remember the 2 out of the 3. So as we discussed earlier, Megan and Paula, basically in the medical decision making, this came out to be moderate. So we couldn't bill a 99233 because it's not high medical decision making. Let's take a look at another note. This patient is being seen and evaluated, sitting up in the chair in no distress, reports esophageal, abdominal pain and nausea this morning, but no vomiting. We have an active problem list. They have no other acute complaints. Let's talk about the exam again. We have vitals, which is 1. We have eyes, 2, ENT, 3, cardiovascular, 4, respiratory, 5. We have GI, 6, musculoskeletal, 7, skin, 8, neuro, psych. So we have more than enough elements in our exam. They're reviewing some labs. Going over some medications. And in our assessment and plan here, we have acute on chronic GI bleed, blood loss anemia, CHF, coronary artery disease, COPD, we have diabetes, CKD, hypothyroid, GERD. So let's talk about this one. I also did not audit the history on this one because the same thing. This is a sub-care note. As you can tell, and we don't have a past family social history. don't have all the complete review of systems. There's no need for me to do that, the history section. We went straight to the exam. So in putting it together, we have our exam meets comprehensive, our detailed for the highest. We had more than 4 problems that we were addressing here, but 4 is the most you can get. So, and none of them said that they were unstable or worsening. So we have 4 problems. In the data section, they did talk about an X-ray, and we had labs back here. So in putting that together, we have 4, and then in the data section, 2 with the radiology and the labs. So down to the table of risk, we have 4, we have 2, and then we have many ways to look at this one again. We have 2 stable chronics. We have an acute illness with symptoms. We also have prescription drug management because they're continuing them on all types of medications. But nothing in this note is pointing, or it's all stating to basically continue this type of medication. There's nothing alarming with this patient. Continue their synthroid. So again, this one comes out to a 99232. So we're going to move on to another note. We have procedures during our hospitalization. We have that there is an ERCP done. The findings of the ERCP. We have consultations that during this hospitalization, GI was consulted ID. We have a brief HPI. We have a past medical history. We even have a surgical history. We have a family history. We have when they came in during admission, what their home medications were. We have their hospital course and all the problems that were addressed during their hospital stay. We have that they had a CT and what the findings are of the CT, as well as an X-ray, and what their discharge medications are going to be. And we have wanted to point out that it says patient seen and evaluated on the day of discharge. So this is our discharge exam. We have our discharge exam here. And then at the very bottom, if you look, the provider documented greater than 30 minutes was spent in discharge planning. So when we put this together for our discharge, we needed an exam and basically to know what was our discharge management. We basically needed to know, was the patient going home, how much time they spent discharging the patient, and did they perform that exam that day. We had all of that. They documented greater than 30 minutes, so we were able to bill at 99239. Had they not documented that they spent greater than 30 minutes, then we would have had to bill the 99238. However, I think that it is best practice to document your time, whether you spend greater than 30 minutes or not. It's just good practice to document your time as far as your discharge goes. Also, I want to point out that that was a discharge summary that we were looking at. We do not usually use the discharge summary to bill from unless they do a face-to-face exam on that discharge summary. So if that discharge summary had not stated that that exam was done on the day of discharge, and it just had all of the hospital, their hospital stay, then we wouldn't have used that. We would have looked for a progress note to give us the information of the patient being discharged. Let's take a look at this note. I have an HPI. You can see that consult was requested for blood glucose management. We have severity. We have modifying factors. We know what kind of medication the patient's taken. We have duration because she's had diabetes for 10 to 15 years. We have timing because she checks her blood sugars most mornings. So we have modifying factors. We have severity. Her blood sugars have ranged from 124 to 251. So we have severity, we have modifying factors, we have timing, we have duration. So we have 4 elements of HPI. We have labs. We have review of systems. Make sure that we have 10 review of systems. We have constitutional, 1, integumentary, 2, eyes, 3, ENT, 4, cardiovascular, 5, respiratory, 6, GI, 7, GU, 8, musculoskeletal, 9, and neuro, 10. So we have our review of systems. We have a past medical history. We have our social history. We have our family history. We even have a surgical history. They're reviewing the patient's allergies, inpatient medications, physical exam. Look at that and make sure we have an 8-organ system exam. We have constitutional. We have cardiovascular, 2. We have respiratory, 3. We have abdomen, 4, neuro, 5, skin, 6, musculoskeletal, 7. And I skipped one, ENT, 8. We have blood glucose and insulin that was given. For impression and plan, or assessment and plan, this patient has type 2 diabetes that is not controlled. They have hypoglycemia. For long-term insulin use, no, but they're on a high-risk medication. So in looking at this, we had our 4 elements of HPI. We had all of our review of systems. We had our past family and social history. We had our 8 organ system exam. This is a consult. So this was a new problem with additional workup. So that's 4 points. They reviewed labs, which was 1. So in putting this together, we have 4, 1, and then we can look at this as type 2 diabetes is not controlled as a chronic mild exacerbation or side effects of the treatment. Or we could look at it as also as they're doing prescription drug management. So we have the 4, we have the 1, and then moderate decision making. So with this consult, again, the history is comprehensive, the exam is comprehensive, and the medical decision making is moderate. Remember, this is like an initial. You have to have 3 of the 3. So this would be a 99254.
Make a recommendation. I don't know if anyone else is in here in a consult service, but you can game the data portion of this really easily by having statements in your template.
Oh, absolutely.
So
Yeah, well, as auditors, we can tell what's been copied.
yeah, exactly.
Yeah,
Well, even just, so like when I write a consult note, like my stuff pre-populates, like the labs are brought in and stuff, but I always document that I spoke with whatever provider. That's 2 points. Always make sure that you have stuff auto-populate. The purpose of this, reason I came here was to try to get more tips to make sure my billing was
absolutely.
top-notch, so.
Okay, create the template so
Exactly, so that you can bypass all this, make sure you're billing at the top level, because this stuff is easily forgotten, so.
You're,
you
yeah,
know.
absolutely.
Just make sure that you don't have things auto-populating.
Right, then I need the asterisk, but statements like I have independently reviewed, 2 points right there. I
Right.
have discussed with, there's 4 points right there.
Exactly, and that's a very valid point. I would say that most providers will fall short in the data section because I'm sure that there's probably a lot of things like picking up the phone and maybe speaking to another provider, healthcare provider, and stuff that they may do that they just didn't document. Now, questions? Comments? Everybody all confused? Thank you so much for your time.